Good morning, everybody. So today we shall be discussing general principles and management of poisoning. General principles and management of poisoning. These are the learning objectives for today's class. At the end of the class, BSc Nursing third year students should be able to, firstly, define a poison. Define a poison. Describe diagnosis of poisoning from history, examination, and investigations. Describe principles of management. And fourthly, discuss duties of a nurse in a case of poisoning. Is it clear so far?
Yes, ma'am.
What is a poison? A poison is defined as any substance which, when taken into the living body or brought into contact with any part thereof, will produce ill effects or death by its local or systemic action or both. This is the definition of a poison. Toxicology is the science that deals with the properties, action, toxicity, lethal dose, estimation of and treatment of poisons. It can be remembered by the mnemonic PATLET, P-A-T-L-E-T. Properties, action, toxicity, L for lethal dose, E for estimation, and T for treatment. Can we move on to the next slide? What is a toxicological emergency? Now, many poisoning cases will be brought to the casualty, and you may be the nurse on duty. What is a toxicological emergency? A toxicological emergency is any case of acute poisoning or an overdose of drugs. Somebody may be addicted to drugs and may have taken an overdose, like morphine, heroin, or intake of substances of abuse or illegal substances, or over-the-counter medications and prescription drugs. Sometimes we don't wait for the doctor to prescribe medicines. We take something on our own, and this can lead to harmful effects. So this can become a medical emergency. Exposures to poisons can occur through inhalation, by inhaling the poison, by ingestion, that is through the oral route, by injection, that is through the intravenous route, or contact with skin and mucous membranes. For example, an organophosphorus compound. Somebody who is working in the fields or a farmer is spraying an organophosphorus insecticide. So accidentally, this insecticide in liquid form may come in contact with the skin, and if it is absorbed through the skin, it can cause harmful effects, either locally, or if there is systemic absorption, if it is absorbed into the bloodstream, it can cause systemic effects also. How do we diagnose poisoning? So diagnosis is based on history, physical examination, and investigations. When a case presents to casualty with alleged history of poisoning, there should be a reliable history of exposure to the poison. Information, either from the patient himself or herself, or if the patient is not in a state to give information, patient may be brought in unconscious. So in that case, it is the attendant or the relative who will give the history. Information regarding use, abuse, or intake. The relative may give a history of drug abuse, a person who is addicted to a particular substance, alcohol intoxication. The route of exposure. Was the poison injected or taken through the mouth orally? The reason for exposure. The patient may have been going through some form of depression or stress, which caused him or her to take an overdose of the drug or poison. The past medical history. history of drug abuse, history of medication, and circumstantial evidence, presence of tablets, empty containers and capsules at the scene of the incident. So, this is the history that you may gather from the relative or the attendant of the patient. Then you move on to do a physical examination. General examination, pulse, BP, respiration, temperature, the level of consciousness, Glasgow Coma scale. Okay, is the patient conscious and oriented, or is the patient semi-conscious, unresponsive? The general state of awareness. Any odors or smells emanating from the person. Some poisons have characteristic odors like the smell of kerosene or smell of alcohol, smell of cannabis in case the person is an addict. Then physical examination, inspection, palpation, percussion, auscultation. Auscultation of the heart. A systemic examination is done, respiratory system, whether the breath sounds are audible or not. The heart sounds, abdominal sounds. So, a systemic examination covering the respiratory, central nervous system, respiratory system, and per abdomen. A complete physical examination is done. Then some samples may be required for investigations. For example, drug levels can be analyzed. So you can preserve a sample of blood or a sample of urine for analyzing the presence of particular substances in these body fluids. Levels of glucose, CBC, a complete blood count can be done. Arterial blood gas analysis, because many drugs and poisonous substances are known to cause derangement of, electrolytes. Okay, and they may cause metabolic acidosis. A chest X-ray can be done, especially in the case of respiratory poisons, those which act on the respiratory system like inhalants and other asphyxiants. Serum and urine toxicology. You can preserve a sample of urine. Urine is a very good sample for analyzing drugs of abuse. For example, if a person has taken an overdose of heroin, the metabolites of heroin can be detected in urine. So a sample of urine can be preserved. Blood levels can also be done. What is the approach to management? So this is called the ABCD. ABCD of management. A stands for airway, B for breathing, C for circulation, and D for depression of the CNS. So the first approach is stabilization. When a person comes to casualty in an unconscious state with history of, alleged history of poisoning, the first step is to assess and manage the airway, breathing, circulation, and to assess the level of central nervous system depression. Is the patient conscious and oriented? Is the patient responsive? Is the patient in a comatose state? Provide supplementary oxygen if required, and obtain intravenous access. Start an IV line right away. So medicines can be given as given in the doctor's orders. Medicines can be administered as per the doctor's orders. If there is a poison information center in your institute, here we don't have one, but in some hospitals or in some states, there is a poison information center where information can be given about the poison, about the signs and symptoms. And somebody from the Poison Information Center gives information, based on the symptomatology. They give, a list of possible poisons which may have produced that particular symptomatology. So it is a very useful source of information, but unfortunately we do not have one in our state right now. And speed is of the essence. Okay, that is why it's called an emergency. In an emergency situation, the faster you attend to the patient, the better it is. If there is any delay, it may cause the patient's life. So speed is of the essence. And the first 1 hour after poisoning or injury is the most crucial. It is called the golden hour in emergency medicine. The first 1 hour after injury or poisoning. Then there are certain interventions which can be done. For example, decontamination. If a poison has been ingested or taken orally, that poison can be removed from the gastrointestinal tract. That poison can be removed from the stomach. So ideally, poisons can be removed from the stomach within 3 to 4 hours because the gastric emptying time is 3 to 4 hours. Okay, so if a gastric lavage or stomach wash is done within 3 to 4 hours of ingesting the poison, it can be more effective. Then there are special measures to eliminate the poison: hemodialysis, hemoperfusion, antidote administration if indicated. Antidotes are substances which neutralize or counteract the effect of a poison. Unfortunately, antidotes are not available for every poison. In fact, in our setup, less than 5% of cases of poisoning, an antidote is available. Okay, an antidote is available in less than 5% of poisoning cases. And the mortality is high in India. Say in the developed countries, it may be 1 to 2%. But in India, it is almost, 10 to 15% mortality due to poisoning. And of course, the mainstay of treatment is symptomatic and supportive therapy. So there is an emphasis on supportive measures, maintain the airway, breathing, circulation. Okay, supportive treatment forms the mainstay of therapy. So now we come to gastrointestinal decontamination. How do we remove the poison from the gastrointestinal tract? So the most common or most commonly employed measure is a stomach wash or gastric lavage. And we can also use activated charcoal. There are emetics like syrup of ipecac. Emetics induce vomiting, but these are not used routinely because there may be other side effects due to forceful vomiting. Then there are cathartics which stimulate the bowel. Cathartics like sorbitol, magnesium sulfate, and magnesium citrate. These hasten the elimination of the poison through the rectum and anus. Okay, so the poison is removed completely from the gastrointestinal system. Then there is a method called whole bowel irrigation, where fluid is passed through the whole bowel, or fluid is passed through a tube, and it washes the entire bowel, and this fluid comes out through the rectum and anus. And the solution which is commonly used is polyethylene glycol electrolyte solution. Is it clear? Is it clear? Please respond. Okay. So I'll be moving on to the next slide. Okay. Gastric lavage or stomach wash. How is it done? Okay. Have you been posted in casualty? Have you been posted in the emergency department anytime?
Yes, ma'am.
Yes. Okay. Have any of you seen a gastric lavage or stomach wash being done? No, not yet. Okay. So gastric lavage or stomach wash. Okay, basically you're just washing the stomach. You're passing a tube either through the mouth or the nose, and then you're passing some fluid through the tube to wash out the stomach. So this removes the toxin or the poisonous substance from the stomach. So how is this procedure carried out? So first you must take informed consent from the patient. You must tell the patient what you're going to do. Of course, if the patient is unconscious, you have to take care, to maintain the airway, okay, to protect the airway so that this regurgitation or aspiration of gastric contents does not take place. So take an informed consent. If the patient is conscious, take an informed consent from the patient. Make the patient lie down in the left lateral position, left lateral or semi-prone position, and raise the foot end of the trolley by 20 centimeters. The patient can be made to lie down on a trolley. Otherwise, you can raise the foot end of the bed or wherever the patient is lying on. Okay. I'll just show you a picture so that it is more clear. Can you see over here? So this is the semi-prone position. It can be left lateral or semi-prone position. And the foot end of the bed, you cannot see the foot end here. The foot end of the bed can be raised so that the fluid comes out, or the contents of the stomach come out by gravity. Okay. Then you use either you can either use this Boas tube. Can you see this orange tube here? Okay, this is called a Boas tube. And this is the end which you will introduce through the mouth. This is introduced orally. It is called a Boas tube. You can also use a Ryle's tube. Okay, I think a Ryle's tube produces less discomfort. This can be introduced either through the nose or the mouth. Okay, so this end is introduced through the nose or the mouth. Then measure the distance of the tubing from mouth to epigastrium. You should know how much to introduce. Otherwise, it can cause perforation of the stomach if you introduce too much of it. If you keep passing the tube, it can cause perforation of the stomach. So you measure the distance from the mouth to the epigastrium. That will be the length of tube that you introduce. Okay, you will be learning this procedure. This is an important, skill which you learn during your practical or clinical posting. Okay, this is a skill which you will all have to learn, because even a feeding tube is introduced in this manner. Okay, so if you take the Ryle's tube, it is roughly 50 centimeters in an adult and 25 centimeters in a child. Okay, then the tube has to be lubricated. You cannot pass the tube directly without lubricating it, otherwise it will cause some friction and discomfort when you're passing the tube. So you have to lubricate it, okay, with lignocaine jelly, and gradually pass it down. Okay, either orally or nasally, through the nose or through the mouth. Pass it down. You can see over here, gently inserting the nasogastric tube into the nostril. Okay, this is a sterile procedure. You have to wear sterile gloves, and this has to be a sterile tube that you're passing through the nose. Okay, it can also be passed through the mouth. Okay, here. It can also be passed through the mouth. So confirm correct placement of the tube. You have to make sure that the tube is in the esophagus or the stomach and not the trachea. Because as you know, anatomy, trachea and esophagus are very close by. The tube may have inadvertently passed into the trachea. Okay, so you have to confirm that it has passed through the esophagus into the stomach and it is not in the trachea. Siphon of gastric contents before lavage and save a sample for analysis. So you can take a syringe. You can take a syringe, and from here you can siphon off some of the contents. You can suck out some of the stomach contents. Okay. So this first gastric aspirate is very useful for chemical analysis because it will contain the highest concentration of the poison. So siphon of gastric contents before lavage and save a sample for analysis. Small amounts of lavage fluid, approximately 200 ml, are introduced through the funnel. You can see this funnel here. So it is raised above the level of the patient. Okay, so that by gravity, the fluid will enter the stomach. So it can either be, tap water or normal saline. Okay, these are the common gastric lavage fluids that are used. Okay, most of the time in casualty, tap water is the most readily available. So even that can be used. Although several types of lavage fluids are mentioned in the books, solution of potassium permanganate or lime water. Many solutions are mentioned for specific poisons, but the most commonly and readily available is tap water or normal saline. So these can be used without causing any harmful effects. Okay, so you pour down, okay, 200 ml at a time, you pour the fluid in through the funnel. Okay, and allow this fluid to enter the stomach. Leave it there for some time. Then you bring this funnel down, okay, so that the fluid comes out. That means the contents of the stomach will come out from the funnel, okay, and you pour it into the bucket, okay. Is it clear how gastric lavage is done? Is it clear? Please respond. Okay. So it's a simple procedure. Yeah, it's a simple procedure which you will be learning during your practical or clinical postings. So stomach wash is continued until 3 liters of clear return are obtained. Okay, stomach wash is continued. You pour 200 ml at a time, then you pour it out, pour in, pour out, till the returns are clear. Okay, then you know the stomach has been washed thoroughly. Is it clear? So what are the contraindications? Okay. What are the contraindications? You can use stomach wash effectively within 3 to 4 hours, or some books say even up to 6 hours after history of poisoning, after alleged poisoning. You can use, you can employ stomach wash or gastric lavage. But there are certain contraindications. In poisoning with corrosives, if you pass a tube, a corrosive will cause softening of the tissues. So if you pass a tube, it can cause perforation of the esophagus, of the mucous membranes. Okay, so it is contraindicated in corrosive poisoning, like poisoning with strong acids like sulfuric acid, nitric acid, hydrochloric acid. Ingestion of petroleum products like hydrocarbons. Okay, it is contraindicated because there is a danger of aspiration of stomach contents into the airways. Then in uncooperative or unconscious patients, unless the airway is protected. If you are using in an unconscious patient, you're performing a gastric lavage, you have to protect the airway. Okay. In very old subjects, it cannot be done because there is possible rupture of delicate esophageal varices. So old patients are more likely to have esophageal varices, which can rupture if you pass a gastric lavage tube. So these are the contraindications of gastric lavage. Activated charcoal. Okay, it is very useful in poisoning. It serves as, you can say, a physical antidote. It was first used in 1830 when its effects were shown by the French chemist Bertrand. So the source of activated charcoal is destructive distillation of wood and activated by oxidation with steam at increased temperature. So what it does is it absorbs the toxin onto its surface. It has these pores, on the surface. Okay, this is activated charcoal. So you make a solution of this. You add water and you make a solution or a slurry. And it can either be taken orally or it can also be introduced through the nasogastric tube. It can be introduced through a nasogastric tube. Okay, so what happens is it binds, the molecules of the poison bind to the pores here. It absorbs. Okay, so that is how it acts. Activated charcoal. But there are certain complications, okay, like aspiration of charcoal or gastric contents, and it can also cause intestinal obstruction if it is, not mixed properly. And it is not effective for heavy metals, corrosives, cyanide, alcohol, and petroleum distillates or petroleum products, hydrocarbons, because these are poorly absorbed. They are poorly absorbed by activated charcoal. Okay. Now we come to syrup of ipecac. This causes emesis or it induces vomiting. So the source of syrup of ipecac is the root of a small shrub. So this is available commercially in pharmaceutical shops. Okay, 30 ml can be given in an adult, 10 to 15 ml in a child. Okay, the correct dose should be given, followed by several glasses of water in a sitting position. However, it is contraindicated in children less than 1 year of age, in comatose patients, in corrosive ingestion. When there are convulsions, it is contraindicated, and also in advanced pregnancy. Because, forceful vomiting can have damaging effects. Okay, so it is not routinely used. Syrup of ipecac is not routinely used. Now in the hospital setup, there are special measures to remove the poison. Okay, these are measures to eliminate the poison from the body. Forced diuresis. Okay, hemodialysis, hemoperfusion, plasma exchange, exchange transfusion, and hyperbaric oxygen for inhaled poisons like carbon monoxide poisoning. Hyperbaric oxygen can be useful. Nursing care is very important in cases of poisoning. Nursing care, in fact, forms the mainstay of treatment because antidotes are not available for all poisons. So comatose patients especially need very good nursing care. Patients are turned regularly to prevent pressure sores or bed sores. And the bed linen should be changed frequently. Patients who are comatose may pass urine, feces, and the bed linen may be soiled frequently. So these have to be changed regularly. And comatose patients, you should prevent exposure of the eye. Sometimes the eyelids remain, the eyes remain open. So eye drops, methyl cellulose, those refreshed liquid gel eye drops must be applied to prevent exposure keratitis because there may be no spontaneous blinking in a comatose patient. Or the best way is to close, simply tape the eyelids together. Okay, close the eyelids and apply adhesive tape. Adequate bronchial toilet with regular aspiration of secretions. Okay, because the reflexes may be depressed. These secretions, there may be pooling of secretions in the respiratory tract. And these can block the airway. So they have to be removed frequently. You must have seen, the ICU setup, suction. Okay, so these suction machines are employed, okay, to remove the secretions from the respiratory tract. Passive physiotherapy in comatose patients, again to prevent formation of pressure sores or bed sores. Passive physiotherapy can be done. And prophylactic antibiotics if necessary. So as you can see, nursing care is very, very important in those poisoned patients who are comatose, who are in a coma, who are not conscious. Okay. And in addition to nursing care, psychiatric care is also important. If a patient is conscious and there is history of suicidal poisoning, a person has deliberately taken a poison to end his or her life. So this patient has to be referred to a psychiatrist for counseling. So these are the steps followed for inhaled poisons. So this is a common sight these days. Instead, we all wear masks nowadays to prevent, droplet infection, isn't it? So even in the case of poisons, those gaseous poisons which are inhaled. Okay, so wearing a mask can help to prevent inhalation of the poison. So remove from the source of exposure. This is the first step. If a patient is in a contaminated or vitiated environment, remove from the source of exposure. In a hospital setup, you can begin artificial respiration and administer oxygen. If there is bronchospasm, A bronchodilator like aminophylline can be given intravenously. And if there is pulmonary edema, suppose presence of crepitations over the chest, then injection Lasix can be given at a dose of 40 milligrams. So what is an antidote? An antidote is a substance which counteracts or neutralizes the effect of a poison. There are physical or mechanical antidotes, as I have mentioned, activated charcoal. Chemical antidotes, which act by chemical action. For example, weak acids and alkalis, and potassium permanganate. Physiological or pharmacological antidotes, which produce actions opposite to those of the poison. For example, in morphine poisoning, naloxone can be given to counteract the effect of morphine. And in datura poisoning, neostigmine can be given. Okay, so this is called the agonist-antagonist type of action. And there is a universal antidote, which is a home remedy. It is a combination of physical and chemical antidotes and comprises activated charcoal, 2 parts, magnesium oxide and tannic acid. The home activated charcoal, instead of activated charcoal, you can use burnt toast. Okay, burnt toast. Magnesium oxide, milk of magnesia, which is available in most of our households. And tannic acid in the form of strong tea. Okay, so this was recommended. In fact, if many of us have diarrhea at home, we usually take, toast and strong tea because it helps to counteract the toxins in the system. Okay, but this is no longer recommended for routine use, this universal antidote. There is something called a coma cocktail. If a patient is brought to the emergency department with a history of poisoning and the patient is in a comatose state, so a combination of antidotes called coma cocktail can be given. So this coma cocktail comprises or is a combination of dextrose, thiamine and naloxone. Okay, so this coma cocktail is given if a comatose poison patient is brought to the emergency department. But again, some toxicologists, some authors do not believe that the coma cocktail is effective. Okay, there are divergent views, but it is used in many hospital setups. Then there are chelating agents. These are also type of chemical antidotes. They are substances which combine with metallic poisons to form inert, non-toxic, water-soluble complexes that are excreted in urine. So these are effective in metallic poisoning. For example, BAL, British anti-leucite, or damicaprol. It is effective against arsenic poisoning, mercury and copper poisoning. Okay. Then EDTA, which is effective in lead poisoning. We still come across cases of lead poisoning, chronic lead poisoning. So this is an effective antidote for lead poisoning, EDTA. It can be given by intravenous drip. Penicillamine, which is effective against copper. This is also another chelating agent. Desferrioxamine is a specific antidote for iron. It may be given either orally for unabsorbed iron or intravenously for absorbed iron. Then there is a serological antidote or anti-snake venom, which is effective for snake bite poisoning. So these are examples of chelating agents. Chelating agents are a type of chemical antidote. They are chemicals. So poisons can be classified into corrosives, that is caustic, strong acids and alkalis, irritants, which may be metallic, like heavy metals, iron, arsenic, lead, neurotoxic poisons, those acting on the central nervous system, like alcohol, datura, cardiovascular poisons, like cyanide, which act on the cardiovascular system. Asphyxiants, these are gases, and miscellaneous like food poisons, mushroom poisoning, which is quite common in our state. So this can be remembered by the mnemonic SYNCAM. C, ocorrosives, C, I for irritants, N, C, A, M. Then poisons can also be classified on the nature of use, based on the nature of use, whether it is for a homicidal purpose, that is with the intention of killing someone. Okay, arsenic can be used for this purpose. Poisons can be used with suicidal intent, that is for self-harm. For example, opium or an overdose of barbiturates or other prescription drugs used with suicidal intent, benzodiazepines like diazepam. Accidental poisons, where ingestion of the poison is purely accidental, happens in children. That's why you see right in the first slide, keep out of reach of children. All these substances must be kept out of reach of children, because children have the habit of putting everything inside their mouth and they can be accidentally poisoned. Occupational poisons. Sometimes a person, by virtue of his occupation, may be exposed to a particular toxin or poison. Like, those working in lead factories. Okay, exposure to carbon monoxide or cyanide, again in textile industries. Exposure to phenol in the hospital environment or pesticides, in farmers, those working in the fields. Environmental pollutants, air pollutants, cigarette smoke, contaminated water, and therapeutic poisoning due to overdose of prescription drugs. Now, what is a toxidrome? A toxidrome is a collection of signs and symptoms that consistently occur after ingestion of a particular toxin or drug. So it is very useful to identify a toxidrome. That means, a specific collection of signs and symptoms that you associate with a particular drug or a particular poison. So what are the toxidromes that we know commonly? So one is the anticholinergic toxidrome, which is characterized by dry mouth, hot dry skin, urinary and bowel retention. Okay, these can be caused by atropine, datura, and even mushrooms. This amanita muscaria species of mushroom can cause anticholinergic symptoms. Okay, so this is the anticholinergic toxidrome. That is a set of signs and symptoms which you associate with a particular poison. Then the sympathomimetic toxidrome. This is characterized by hypertension, that is increase in the blood pressure, tachycardia, racing of the heart and pulse rate, sweating, dilated pupils, and irregular heartbeat or arrhythmias. And poisons like cocaine, amphetamines, and nasal decongestants, ephedrine, can cause sympathomimetic symptoms. Then cholinergic symptoms like salivation, lacrimation, sweating, urination, constricted pupils, and seizures, which can be caused by organophosphates and carbamates. These are commonly used as insecticides or pesticides. And finally, sedative hypnotic symptoms. Hypotension, collapse, bradycardia, respiratory depression, pinpoint pupils, coma. This is characteristic of opiates, morphine, heroin, barbiturates, and benzodiazepines. So these are the common toxidromes that we encounter in clinical practice. You can see this chart here with the symptomatology. What happens to the heart rate? What happens to the respiratory rate? Temperature, pupils are dilated in anticholinergic poisoning. Bowel sounds are decreased. And there is decreased sweating. Whereas, let's say, sedative hypnotic, decrease in the heart rate and blood pressure, decrease in the respiratory rate, decrease in the temperature. Pupils are constricted and bowel sounds are decreased. Okay. And opioid, you can see the pupils are pinpoint pupils in opioid poisoning. Okay, so what is the symptomatic triad of opioid poisoning: respiratory depression, pinpoint pupils, okay, and decrease body temperature. What are the duties of a nurse in a case of poisoning? In the emergency department, you will come across quite a few cases of poisoning, a good number of cases. So the first and foremost duty of a nurse is to treat the patient with emphasis on supportive care. Remember, antidotes are not available for all poisons, so the emphasis is on supportive measures. In government hospitals, our hospital is a government hospital, so we have to report every case of poisoning to the police, whether it's suicidal, homicidal, or accidental. Collect and preserve evidence for chemical analysis, because if you don't, then it is a punishable offense. You may be questioned by the court as to why you did not preserve evidence in that particular case. Cases of food poisoning must be intimated to the public health authorities. In our state, we can report to the Directorate of Health Services. If the patient is on the verge of death, record the dying declaration. If the patient expires, do not issue a death certificate. Okay, the doctor cannot issue a death certificate, but the police has to be informed. And in all probability, the police will ask for a post-mortem examination to find out the cause of death. Maintain written detailed records of every case. Remember, record keeping is very important. So, adequate documentation of the case, your case notes. These are important. So, what are the current concepts in management of poisoning? Stabilization of the patient is the mainstay of management in poisoning emergencies. Try to stabilize the patient. Maintain the vitals. Gastric lavage may be considered if a potentially life-threatening amount has been ingested. And gastric lavage is effective if poisoning is within 4 to 6 hours. Otherwise, if the time gap is too much, then gastric lavage is not effective. Routine administration of ipecac in the emergency department should be abandoned. As I mentioned earlier, syrup of ipecac as an emetic to induce vomiting is not routinely used. Activated charcoal is gaining importance in the management of ingested poisons. If poisons have been taken orally, then activated charcoal is quite effective in management. Antidotes play an important role in specific situations. Very specific situations. Like heavy metals, you can use chelating agents. Oxygen is extremely useful for carbon monoxide poisoning. Naloxone is useful for poisoning with opiates. Administration of a cathartic is one which stimulates the bowel, like magnesium sulfate. So by itself, it has no role. A cathartic has no role, and it is not recommended as a method of gut decontamination. So what is the mainstay of treatment? Supportive care, observation and monitoring for a change in clinical status. So this is what nurses do. Observation, monitoring round the clock. Okay, nurses spend more time with patients than doctors, so your role is very important. So just a spectrum of poisoning cases in NEIGHRIMS. This was from the year 2009 to 2012. Okay, but this mushroom is in the year 2015. Okay, so from 2009 to 2012, one case of cannabis intoxication, one case of heroin, battery acid, that is sulfuric acid, one case, 3 cases of kerosene poisoning, 6 cases of datura poisoning, 10 cases of alcohol intoxication, and the majority of poisoning cases were due to consumption of prescription drugs, like diazepam, alprazolam. Okay. So we saw quite a few cases of poisoning by prescription drugs. Then pesticide poisoning, 14 cases. And phenol, 9 cases. Phenol or carbolic acid. And this mushroom poisoning occurred in the year 2015. There were 12 cases in 2015 alone. So that's why we have to take special measures to prevent and treat mushroom poisoning. So that's all for today. Thank you very much.